we are now in the last session today, and we start with our colleague, Dr. Maryam. She's very expert in chest, and she have been recently gained her fellowship from Canada, and congratulations for her first. Then she will give us like her nice experience through her last fellowship she did, and also through her experience through the journey in FRCR, and also she's have been involved in the Omani board, and we have a nice experience with her. So everything today in his side, she will try to give us nice presentation about that. I wish you will enjoy with Dr. Maryam her presentation. And if she's ready, she can start. Dr. Maryam, are you there?
السلام عليكم.
عليكم
كيف
السلام.
الحال؟
الحمد لله. I'm fine. الحمد لله كله تمام. الله يجزيك خير.
الله يسلمك. الله يسلمك. Thank you for the introduction.
Yes, you can start.
So let me just share my screen. See my screen? Projecting well screens.
Yes, it is very nice. Yes, you can see it very well.
So assalamu alaikum. Good afternoon, everybody. And happy to be involved in the scientific day with the first chest lecture series that I chose to present something about the basic chest radiography, the basic concepts and the basic interpretation. Because in my point of view, if we have that solid knowledge of the basic anatomical landmarks and chest radiography, we will be really stronger in interpreting the pathologies later on. So here are my objectives for the lecture today. I've chosen the most important points in the frontal and the lateral chest radiograph. And if we get time, I know we have a time limit of 40 minutes, but if we get time, we will talk more about one of the concepts in chest radiography, which is the lobar atelectasis. What are the direct and indirect science of that? So we can't talk about the basics if we don't talk about the fissures. So starting with the first thing, which is the lobes and fissures. And as we all know, we've got 3 lobes on the right side and 2 lobes in the left side. And therefore we have 2 fissures on the right side, the major oblique fissure and the horizontal minor fissure. And this is really good schematic diagram for both the left and the right lungs. And I really love it because it tells you where exactly the fissures are located. And having that knowledge, when you have, for example, atelectasis, and you see all that volume loss and you see the retraction of the fissures, and then you understand and you can localize your pathology really well. So for example, if you're talking about the right lung here, we can see that the right upper lobe, as we can see it here on the frontals, projecting in the upper aspect of the lung on the lateral view, extending anteriorly and extending posteriorly. And why is that? Because the location of the major fissure or the oblique fissure is just oriented this way. So you can imagine why it stops here. And you can therefore see that the right middle lobe, which is triangular in shape in the lateral view, is projecting over the heart and having that triangular shape because it's bounded by those 2 major fissures, which is the major fissure, the oblique one, and the minor, the horizontal one. And therefore, the lower lobe would be projecting on the posterior and lower aspect on the lateral view. And here's a schematic diagram for the left lung. as we can see, there is a considerable overlap between the left upper lobe and the left lower lobe on the frontal chest radiography. And therefore, if you have a lateral view, that really helps you to locate the abnormality. That's why sometimes, not sometimes, it's actually most of the time, and it's the correct terminology to use when you describe abnormalities in chest radiograph, that you don't say lobe if you're not confident enough to locate the pathology, but rather you describe the abnormality location per zones. So upper zone, middle zone, or lower zone if you're not sure. But we will talk a little bit about localization today that can help you to locate your abnormality if it is within a particular lobe of these anatomical lobes. So let's get to talk about the PA view more details. And as you can see here, they're beautifully demonstrating these stripes and lines on the frontal chest radiography, which I really think they're important to understand because they can act as a very good localizers of anatomy and subtle pathologies. What are those stripes and lines to start with? They're basically nothing but an interface of an air-filled lung tissue and an adjacent soft tissue. And the difference in the attenuation between these two densities gives you that line or stripe. So, for example, the paratracheal stripe here described with this black arrow here, it's nothing but the interface between the air-filled medial aspect of the right upper lobe and the wall of the right trachea and the adjacent fat in the mediastinum here. That produces this line. We have the left paratracheal stripe as well, but it's more apparent always on the right side compared to the left side. Now, this is a very nice location for lymph nodes as one of the differentials that can occur in this location. Talking about another thing, which is the para-aortic line. Let's see, I think it's projecting maybe better here. We can see this is the aortic knuckle, which is nothing but the radiographic appearance of the aortic arch. And then when it goes down to from the arch of the aorta to the descending thoracic aorta, it forms this line which we call the para-aortic line. And it's really very important to look at, particularly in cases of emergencies and acute chest pain, where you would then expect this para-aortic line to be displaced or widened to reflect the changes happening in acute chest syndrome, which can be aneurysm, rupture of aneurysm. Okay, just silent a bit. Which can be aneurysm, rupture of aneurysm, and dissections and all of that. Mediastinal hematoma. So it's really important structure to look for. Looking at the vertebrae, the thoracic vertebrae, we have something called the paraspinal line on either side. So we have a right paraspinal line in here, and we have a left paraspinal line here. So this is a paraspinal line, which is otherwise called the paravertebral line or the paravertebral space, which demarcate the posterior mediastinum and all the differential diagnoses for the posterior mediastinal masses. And it's really important also in the setting of trauma to look at it if in case you have fractures and hematomas in the posterior mediastinum paravertebral locations. In between those two lines, we have a very important line or stripe that I will give it a special emphasis in today's lecture, which is the esophageal recess. Recess, because it's actually a recess. And if you look at it, before we go to the CT, I want you to look at it from the frontal, on this frontal radiograph, and look how it goes here, because the aortic arch, the esophagus arch of the esophagus vein that just turns to the right side in order to drain into the superior vena cava, which is in this location, and then goes all the way straight, a little bit convex to the left side in its proximal third, and then it goes straight all the way down in its mid third and the lower third. This is the normal contour or the normal appearance of the esophageal line on frontal chest radiograph. It's really called recess because it is a recess. And this recess is formed by the air-filled normal lung parenchymal tissue. This is the medial aspect of the right lungs, perfectly the right lower lobe. This is the esophagus vein on the lateral aspect with the esophagus. This is the vertebra on the posterior side, and it's bounded anteriorly by the left atrium. So this recess and these structures give the appearance of the line or stripe in the chest radiography. Let's now look at the differentials that can cause displacement. So what are you looking at in the chest radiography? You're looking for any displacement, any bulging, any abnormal contour, any widening, any thickening of those lines. If you see this, then you are thinking of differential diagnosis and pathologies according to the clinical context. This is the first case we have it today. I think it's having that barium makes the case really clear. So we can see that from this radiograph, the frontal view, that the esophageal line or stripe has a bulge to the right side in its lower 1/3. And the most common cause for abnormalities that can give this abnormal appearance in this stripe is having a hiatal hernia, as we can see it here in this barium upper GI study. So this deviation in this case is caused by the hiatal hernia. What are the other pathologies that can cause displacement and deviation of that line? So think about the esophagus because the esophagus is lateral to it. And if there is any mass in the esophagus, any hiatal hernia, any dilation of the esophagus because of any inferior obstruction, obstructing mass, or any motility disorders like achalasia or scleroderma, that would give that wide displacement and deviation. I think there is, can you please mute, anybody is by mistake opening the microphone, can you just mute it, please? Okay. The other thing is lymphadenopathy. So we can expect that location, which is the paraesophageal, otherwise called the subcarinal lymph nodes that can occur at that location and can give you that widening and deviation of the esophageal recess. The left atrium and the left atrial enlargement can give you this appearance as well as mediastinal abnormalities and masses like the bronchogenic cyst that can widen and deviate the line. So let's look at further cases. This is a companion case because it just looks like the first case I showed you. Look at that retrocardiac opacity. And when you look at it closely, when you follow that esophageal line, you see it actually bulging. So on the lateral view, if you have it, it's really nice to look always at it. It really helps you to look at the abnormalities and give you more insight into it. You can see that opacity is just bulging in the retrocardiac space. And that as well corresponds to the most common cause of that esophageal widening and deviation, which is the hiatal hernia. This is another case, and this is really nice case. If we look at it, we see that there is a large density. There is an opacity that projects in the retrocardiac space. We really see that opacity extending all the way superiorly to the right paratracheal aspect. Not only that, it also deviates the trachea to the left side. That paratracheal stripe, which normally should be not more than 3 millimeters, it's now centimeters in width. So that there should be an abnormality. Look at the hila. Both hila are actually very dense, and that density is really homogeneous throughout. From the superior aspect to the inferior aspect, you can't really see that paratracheal stripe here. It's merging with that opacity. And if you have a lateral view, always look at it. you can see that there is a lumpy, bumpy density that is at and around the level of the hilum. So all of that involvement, multiple locations, multiple compartments, then you're thinking of the very strong possibility of enlarged lymph nodes, as it is in this case, actually. And as I told you, right paratracheal area is really lovely location for lymph nodes. So we can see here they're very avid hypermetabolic, extensive mediastinal lymph nodes here, and all the way extending to the supraclavicular region. And that patient had small cell lung cancer. Now we have that bulge in the right, in the paratracheal stripe. Not only that, there is an air fluid level, and one would expect there's something obstructing the esophagus where it's dilated with air fluid level. Could that be echologiocardia? Could that be an obstructing mass? And if we see the chest X-ray for the same patient, this is the prior chest X-ray, we can see that opacity, there was no air fluid level, but it extends all the way to the right, to the superior right paratracheal aspect. And if we look at the CT scan, that basically corresponds to very dilated esophagus filled with all of that food material. We can see that opacity projecting on the frontal chest radiography in the lingula is actually corresponding to a big consolidation there, and that's expected because we have that all that dilated esophagus and then very high risk of aspiration as occurred in this patient. So that was a case of achalasia. Let's move now to another structure, which is the AP window. I really find it important to look at always, particularly in cases of when the clinician is always asking about, lymph nodes enlargement and lymphoma, especially in pediatric age group, where the lymphoma can present as lymph nodes, and sometimes it's really subtle abnormality. The only thing is that there is an obscuration or obliteration of the AP window because of one of the most common reasons, which is lymph nodes. So if you look at it here, I really like this diagram. That's the aortic arch, that's the main pulmonary artery, and that's the left main pulmonary artery, where in between those two, we have that angle, that lucency, which is the AP window or the AP angle. And look at it, this is how normally it should look like. It is like a bit of a triangular, small concavity here, or it could be straight, but it's never bulging. Once you have that bulge in here, then you are thinking of a pathology happening there. I'll show you a normal chest X-ray in a moment, but just having that insight, how it looks in the lateral view. This is the aortic arch, the pulmonary artery, and this is the left pulmonary artery, by the way. We'll get into it in a minute. And this is the aortopulmonary window in between. It's a bit difficult, but it's more clear on the frontal view. So look at it, that's what I was telling you. It's a bit of a concavity here, a lucency that can be straight, but it's never bulging. The moment it bulges, think of an abnormality obscuring or obliterating that AP window. Here is the first case of the AP window. We can see that there is, this is a very apparent thing. We can see that there is we don't see that triangle here. It's not really straight because it's continuous with a very sharply marginated bulge that occurs at the AP window, and that occurs also at the level of the left hilum. It's obscuring everything here, yet we can still see the left hilar vessels, which is the hilar ovale sign here as well. So looking at the lateral, there is an opacity which is projecting over the level of the left hilum. So what is happening there? Looking at the CT scan, we see that that bulge was actually caused by this soft tissue enhancing mass in the anterior mediastinum, which was later proven to be a Hodgkin lymphoma. So thinking about the AP window, we consider having masses, particularly in the anterior mediastinum. We consider having enlarged lymph nodes. And the other thing that you should think about it is tumors or neoplasms related to nerves, because it's a very good place for nerves to pass through. For example, the left phrenic nerve, the recurrent laryngeal nerve, and the vagus nerve. All of these nerves pass through the AP window. This is the second case here. We have a very large bulge obscuring everything. You barely can see the aortic knuckle through it, and you lose that window, and the opacity and the heterogeneity all of the way obscuring the left hilum as well, and all of that occurring around the hilum on the lateral view. And that was another case of hypermetabolic lymph nodes in the left hilum, in the left mediastinum, and in the supraclavicular area as well. That's the normal uptake in the brain and heart and PET CT. And there was also a case of a small cell lung cancer. Don't be surprised in cases of small cell lung cancer, because sometimes they are central tumors. They are presenting as a lymphadenopathy, hilar mediastinum, that are merging with the perihilar and hilar region with no metabolic, discrete, separate lung primary. That one of the presentations of a small cell lung cancer. Now moving to the lateral view, and the three major points that I want you to really consider when you're looking at the lateral view. First of all, the hilar vessels. That's why I wasn't really touching much upon them, because we will discuss them now. And if we have a closer look, that's the airline here. The first anterior prominent that you always see is a trachea. This is a very nice example of an air-filled esophagus, but it's not usually the scenario. Most of the time it's collapsed. You don't see it, but if you see anything with air that looks very nice like this, then you would think of the esophagus. So this is the trachea, and as we go down, anterior to the trachea, below the aortic arch, as the right pulmonary artery. Posterior to the trachea, and a higher level compared to the right pulmonary artery, as the left pulmonary artery. And I still remember one of the doctors in my residency was saying أهل اليمين في الأمام. So أهل اليمين, the right pulmonary artery, is in front of the left pulmonary artery. So that's the way I remember that. And it's always the left higher in level compared to the right. And this is a really important point. And then you see this, sometimes you see a leucency, which is corresponding to nothing but the left main bronchus, because the left pulmonary artery is at a higher level than the main bronchus, while you don't see any leucency below the right pulmonary artery, because that goes along and at the same level of the right main bronchus. I think these points are really good to remember for the FRCR anatomy exam. And that's it for the vessels in this view. Let's have them in another schematic diagram here. We can see that's the trachea as we go down. That's probably the arch of the aorta. This opacity here corresponds to the right pulmonary artery. This one here corresponds to the left pulmonary artery, and below it is the left main bronchus, which isn't here. We don't see that one because they're at the same level. So the right artery would obscure that bronchus. And the frontal chest radiography, same concept as we said, left is always higher compared to the right. In cases of collapse, where there is volume loss depending upon the location, and the hilum can then be pulled, it can be pulled superiorly, can be pulled inferiorly, but that's a point to consider, but always this is at lower location compared to the left. Now, this is just a schematic diagram to just show you all of these anatomy. This as a thick slab reconstruction from CT scout, sagittal view. Pulmonary veins can be seen, but I don't want you to always, when you see an opacity on the lateral, to just comment it as a normal pulmonary veins. They're not always visualized, to be honest. And this is just a thick flap to show you the anatomy. But if you see this, I would rather call it an abnormality in the chest, lateral chest radiograph, and I'll look at it in the frontal and depending on the scenario, get a CT for that. That's not normal. This is a thick slab where you see the pulmonary veins here projecting very well. Second thing to look at is the diaphragm, sorry. So the diaphragm saluting in the frontal and in the lateral. We tend to look at it always in the frontal, but it's really good to have an insight to what's happening on the lateral view as well. What is pointed here by the red arrows is the IVC as it enters into the left atrium. And those two things are the diaphragm, sorry. So the first one here, the red one, that we can follow it from the anterior aspect all the way to the posterior aspect should be the right side diaphragm. Why? Because I know the left is sitting below the heart, and therefore soft tissue density interface with soft tissue density will make it not clear and will not be able to trace it anteriorly. Let's follow the left hemidiaphragm then. This is the posterior aspect of the left hemidiaphragm. As we go anteriorly, it just merges with the heart above and the soft tissue in the abdomen below, and then you can't really follow it all the way anteriorly. That's the way you know this is the left hemidiaphragm. Third important point in lateral view is dark spaces, and we've got 4 important areas to look at in the dark spaces, which is the retrosternal area. Just let's have this one. The retrosternal space, this triangle here that is above and anterior to the heart and just behind the sternum. This is a hidden area in the lateral view. You always should look at it. Any opacity here will make you think of an anteriorly located opacity, whether in the anterior mediastinum or anteriorly located pulmonary, meaning lung abnormality. The other space is the retrocardiac space. And this always should be lucent and dark. And if there is any opacity here, then that should catch your eye. Then you should look at it. The other thing is when you go down the spine, as you go inferiorly, the spine should become lucent. If it loses this lucency and becomes dark, if it becomes, in simple terminology, white, if there is any opacity here in the inferior aspect of the thoracic vertebral level, then that is abnormal, and we call it the spine cyan. This is the 4th place that you should look at it. This space is called the retrotracheal or the Ryder's triangle. And it's a bit funny. I remember something a bit like when I was a resident as well. There was a lecturer who came. He's now my supervisor, and he removed the R and put H because his name was Hader, and he called it Hader's triangle. Don't forget to look at Hader's triangle. So what is Hader's triangle? It's basically a retrotracheal a triangular lucency and opacity. As we can see here, it's bounded by the thoracic vertebrae posteriorly, the trachea anteriorly, the arch of aorta inferiorly, and the thoracic inlet superiorly. It's a tricky space. And if you don't look at it, you'll miss an abnormality. So always have a look at this very nicely projecting here triangular space. Keep in mind the patient should have their arms raised up, because if they don't have it raised up and all of that auxiliary soft tissue, that fat obscures all this area, you wouldn't be able to see anything on the lateral view, to be honest. But if you have a good lateral X-ray, always look at that Ryder's triangle. Lesions in the retrotracheal space could include vascular lesions. One of them is the apparent subclavian arteries or the double aortic arch. Anything in the esophagus, because remember, the esophagus is behind the trachea, so any mass in the esophagus, any diverticulum filled with fluid in the esophagus would have that opacity projecting on that Ryder's space. Any mediastinal masses, and of course any abscesses, depending upon the scenario. Let's get into the cases. That's case number 1. I don't think we have enough time, maybe 10 minutes more. Okay, I'll try to make it faster now. looking at that case, we can see that there is obscuration of that retrosternal space, which corresponds to large widening of the mediastinum all the way here, and obscuration and goes all the way into the hilum with hilar overlay sign tells me that there is something in the posterior or anterior mediastinum. And I see the lateral view, I see those opacities in the retrosternal area, and therefore I know this is anteriorly located, and that was a Hodgkin lymphoma, anterior mediastinal mass. Always think of those 4T's differential diagnoses of the anterior mediastinal masses. That's the second case. Look always at this point inferiorly. It should never be opaque or have any opacity. And there you see that there is some opacity and bulge there. That's a very lovely place for hernias, for diaphragmatic hernias. And in this case, we can see it's a fat-containing bucdelic hernia in the left posterior hemidiaphragm. This is a nice one because that nice Radar's triangle is not seen, and there's opacity projecting just posterior to the trachea here. So the CT scan demonstrates a left-sided aortic arch with that right apparent subclavian artery passing all the way posterior to the trachea and going to the right side, and that has caused the opacity in the Radar's triangle. This is just a companion case for the same pathology where on barium or upper GI study, it can cause that indentation on the esophagus, because the esophagus as well is anterior to that apparent vessel, the right subclavian artery, and gives it this deformity, which is called the bayonet deformity, the bunduqiyya, and the patients usually presents with dysphagia. I love this case. It's really nice case. You can see how there's a big opacity there in the Radar's triangle. Not only that, there's a bulge all the way there, just behind the trachea. CT demonstrates two pathologies causing this. One is the right apparent subclavian artery rising from the left, loss of branch from the left aortic arch, and mass from the esophagus, narrowing the esophagus, and that's why the patient was having dysphagia. This was esophageal carcinoma in a patient who has apparent right subclavian artery. Very good article about the Radar's triangle and all of those pathologies in Radiographs, and this is the reference for it. Now, touching a bit on the hilum, we have already talked about it, but just a couple of few points here. So we talked about it in the lateral view. That's the right pulmonary artery. That's the left pulmonary artery. It's posterior and superior in level to that right one. And these are the pulmonary veins, which you can see sometimes arising from the left atrium and oriented horizontally compared to the vertically oriented pulmonary arteries. This is a very nice point to remember. It's really practical, particularly when you have just abdomen CT, and you're looking at the lower cuts of the chest, and you see pulmonary embolism, and then you're thinking, is this within a vein or this is within an artery? Because you don't have the upper cuts, obviously, right? This is a very practical point. If the vessels are oriented horizontally, those are veins. If they are oriented vertically, those are pulmonary arteries. And I brought this one because I remember it from Dr. Mahmoud Saidi lecture, the little fingers in the hilum, and those are corresponding to the lower lobe or the interlobar vessels, actually. When you look at it, always look at those little fingers, because sometimes they can be siloted, they can be displaced, or importantly, they can be enlarged. And the enlargement has differentials for that. So when we look at it, usually it's actually more common. I think 90% in the right side, the interlobar artery is more obvious compared to the left side in most of the chest X-rays. And it's for the FRCR anatomy. It was always a question that says they'll put an arrow at this and they'll say what's the normal size in male and female. I know that's why don't go that deep, but that's the interlobar artery. It's 15 millimeter in females and 16 millimeter in males. And that's the interlobar artery, schematic diaphragm. And let's get into cases. So what do we see here? We see a very sharply demarcated triangular opacity that is on the right medial lower aspect, and we don't see that little finger. That little finger was obscured because this is a case of right lower lobe collapse, and the opacity is projecting over the inferior or the lower aspect of the vertebra. And that's a case where where you wouldn't see that finger because it's obscured in the collapsed lung. This is right lower lobe atelectasis. So what do we have here? We have very big fingers. So look at that hilar vessels or the hilae. They're very enlarged, right? I wouldn't say vessels because we don't know. There could be vascular enlargement, it could be lymphadenopathy, it could be masses, could be multiple regions. But the two important things to remember always in the hilar enlargement are lymph nodes and vessels. When you have a lumpy, bumpy appearance, think of lymph nodes. When you have a tubular enlargement, think of vascular enlargement. If you have, in this scenario, a right paratracheal stripe very enlarged, you're then thinking about in the tract of lymph nodes because you have it in multiple locations. And that is exactly in this case, which is 1, 2, 3 sign, beautifully described in sarcoidosis, otherwise called the lambda sign, when you have right paratracheal and bilateral hilar lymphadenopathy. That's another case. And I find that this case is really better than the previous in demonstrating the lumpy, bumpy appearance of the hilar enlargement. And of course, when you have that right paratracheal stripe, always think of the lymph node tract rather than the vascular enlargement. And look at those lumpy, bumpy appearance on around the hilar. Amazing appearance on the lateral view. These are the reasons and the differential diagnoses for the hilar enlargement. Tumors, most importantly, lymph nodes with all the differentials, primary and metastatic, could be in the setting of infection, obviously TB, could be in the setting of granulomatous diseases like sarcoidosis, particularly if it's bilateral with right paratracheal, and could be vascular enlargement and enlarged pulmonary arteries. Hidden areas, really important to touch on them before we end the lecture today. And 4 important hidden areas to talk about are apices, hilae, retrocardiac spaces or space, and all the shadows in lung zone that project inferior to the diaphragm. They are projecting inferior. In anatomy and CT, they are basically posterior to the diaphragm. It's a very important area to look at. If you don't look at it, you will miss a very big abnormalities, which can be fatal. So these are another schematic diagram of those areas. Let's have our first case of this. What do you think? From the first insight, you would think this is a completely normal X-ray, yeah? But if you have that approach, you have that checklist when you look at your frontal and lateral chest radiographs, checking that areas below diaphragm is not looking really nice on the side. There's a big opacity here. Huh? Nothing else in the lung. And in CT, that was a big established lung cancer, probably with some lymphangitic carcinomatosis locally around it. So always look for your hidden areas. The other thing here is this is definitely a difficult case compared to the previous one. Very subtle opacity that projects below the diaphragm, but look at the lateral projection. There is an ill-defined opacity at the inferior aspect of the thoracic spine. So there is a spine sign, there is an opacity here, and that was pneumonia or airspace consolidation in the right lower lobe. Now, what do you think here? Where is the abnormality? It's very subtle, huh? But you can see that there is a retrocardiac opacity with spine sign. So that was another airspace or consolidation in the left lower lobe. Now, we would add this one as maybe a plus or fifth hidden area to our 4 areas, which has this particular area corresponding to the costochondral junction of the first rib. We usually mistake that for masses, an elderly where there is degeneration, and that not the scenario in this case, because this is very unilateral and this is a very well-defined opacity. So look at it always, look at that area of the first costophrenic angle, and that actually corresponds to opacity projecting also on the lateral view, and that was cancer in this scenario, which was already metastasizing to the liver, lymph nodes, of course, yeah, the liver and bones as well. And this lovely emergency case here, when you check your hidden areas and under diaphragm, talking about the lung under diaphragm and talking about free air under diaphragm, we have here a pneumoperitoneum. Now, just 2 minutes maybe talking about this siloxane. Siloxane, what is it? For example, we will take the left heart border. The left heart, so before we take this example, just let me explain what is this siloxane. So there is usually a sharp margin or sharp border of the heart and the diaphragm. You should look at them when, like, this is the normal appearance. They are sharp because there is an interface between the air and the lung and that soft tissue. When you lose that normal sharp border, then, and there is an opacity, that really would help you localize where is that opacity is located. And this is an example in the left heart, where if that opacity is not actually siloting the left heart border, you still see normal silote, you still see sharp border of the left heart, then this must be located in the lower lobe, because what is bordering the left heart is the lingula part of the left upper lobe. What is bordering the right heart is the right middle lobe and not the right lower lobe. If we have an abnormality, for example, in this scenario in the left lower lobe, then what should be siloted is the diaphragm if that abnormality extends all the way to the diaphragmatic aspect of the left lower lobe. So in this, we know the silote sign because the abnormality was in the lingula and the heart border merges with the abnormality, not anymore sharply demarcated. This is just the same example. We just described that schematic diaphragm where the lingula is involved beautifully on the lateral view. You can see that oblique fissure. Look how beautiful it is, separating the upper lobe, that's the lingula affected part of the upper lobe, from the lower lobe, which is free of that consolidation. This is now the same thing. We can see it very sharply demarcated. That's a normal silote. So this opacity must be located in the lower lobe, as we can see it here from the lateral projection. Now let's play the game the other way around in this lateral view. Obviously, we can see an opacity here. We have a spine sign, we have opacity in the retrocardiac space. And where is it? We know it's located in the lower lobe, right? But looking at the diaphragm, applying the silote sign to the diaphragm, we said the right diaphragm, we see it anteriorly, but we have to follow it up all the way to the posterior aspect. We don't really see it posteriorly. That helps you to locate this abnormality without looking at the frontal view, that this is the right lower lobe pneumonia, not left lower lobe pneumonia, because you can see very sharply demarcated normal left hemidiaphragm until it abuts the heart, and then you can't follow it anteriorly, which is the expected normal contour of the left hemidiaphragm. Looking at the frontal for that case, this is just an explanation of what I said. And looking at that case, it's truly right lower lobe pneumonia. So silote of the diaphragm in the lateral view, not only the frontal view. Mediastinum. Take a deep breath. We're not going to talk about the mediastinum. That's a very long, separate lecture in the future, inshallah. And don't be terrified. Those are just very overview of the differential diagnoses of different mediastinal compartmental pathologies. Increase. Do we still have time?
About 2 minutes. Uh,
2 minutes. So I think we should
it
stop
is
here.
very amazing. Yeah, well, it is very amazing, and this is nice because we will be excited to continue this in next scientific day. So everyone will be like waiting for this lecture. It's very amazing, to be honest, and we will like make some تشويق for the next session, inshallah, on scientific day. So if there is any questions regarding the session. So yeah, well, it is amazing. Thank you so much, Dr. Maryam, and very nice presentation, as expected. So now we will